Good afternoon, everyone. My name is Mani Jagdishan. I'm the director for this facility, Chinmaya Somnath. On behalf of the Chinmaya Somnath and the CMWRC, Chinmaya Mission Washington Regional Center families, I would like to invite this wonderful panel. Thank you so much for taking time to be here. And I also want to welcome the audience who are here and over the Zoom. I know this is a very important topic. I'm sure we are going to have a very meaningful conversation for the next 90 minutes. Richa ji is going to do the actual welcome note. I just want to briefly say something. I'm going to turn it over to Richa ji. So it's a very quick talk. Welcome you all. Thank you.
My name is Richa, and I'm the Outreach Coordinator for Chinmaya Mission Washington Regional Center. So I'll be moderating the session today with our esteemed panelists who have taken time from their busy schedules to be with us today and answer questions you have in the audience, either in person or even you can submit using the QR code that was provided online. These questions will be kept anonymous, so there is no reason to hesitate asking anything that's on your mind. And I'll take a few moments to introduce each panelist. And after that, I'll ask some questions to all of them that have already come to us during the registration process. So that will give you a chance to catch up and decide what additional questions you might want to ask them. So first, let me welcome the two co-organizers of this panel. Ami Patel is the third-year PhD student in the school psychology program at the University of Maryland, College Park. She holds a master's degree in counseling and previously worked at Children's Hospital of Philadelphia as a research coordinator for several large grants. So she has experience working with K-12 settings along with cognitive assessments. Next, we have Dr. Niku Singh, who is dedicated psychiatrist and CEO and medical director at Tyson's Psychiatry. He also maintains faculty appointments at the George Washington University and Virginia Commonwealth University. Combining his understanding of neurobiology and chemistry to philosophical and psychological theories of the mind, Dr. Singh lectures nationally on the topics of schizophrenia, bipolar disorder, depression, and psychopharmacology. Dr. Singh also gives back to his community via many philanthropic efforts and has given his time pro bono for asylum seekers and multicultural integration efforts. Next to Dr. Singh is Dr. Shada Baharani, who is a board-certified family medical physician. As you can already see, we have quite a variety here. Dr. Baharani is passionate about listening to her patients and working with them to take care of their health in a holistic manner. She cares for patients of all ages, from newborns to the elderly, to manage preventive health and treatment of chronic medical conditions. We also have Dr. Sonia Koteja, who is a licensed social worker. You get an honorary doctor to be on this panel. She works directly with the children and families involved in the Child Protective Service system. Currently, Sonia has a private practice and provides mental health counseling to adults struggling with anxiety, low mood, difficult familial relationships, and life transitions. Her specialization is in working with adult children of immigrant parents from the Asian diaspora. Next to Sonia is Dr. Shri Gogineni, an internist who blends modern technology and traditional medicine to practice preventive health care, focusing on both mind and body as a way to help people become fit and happy. Additionally, on how various health conditions can affect the body. Next to Dr. Gogineni is the second co-organizer for this panel, Sudhita Kasturi, who is a certified attention deficit hyperactivity disorder coach. She's also the founder and owner of Leverage Your ADHD. She's on the board of ADHD Coaches Organization and is a facilitator for Attention Deficit Disorder Association's South Asian Peer Support Group. She specializes in managing symptoms of ADHD and leveraging its positive attributes. Our final panelist today is Dr. Tanjeena Ahmed, who is a licensed clinical psychologist providing services at a private practice with focus on trauma, women's mental health issues, including postpartum depression and the adjustment to motherhood, managing health-related concerns, and general mood and anxiety disorders. She has expertise in cross-cultural adjustment and identity with an interest in the impact of ethnopolitical psychology on immigrant families and provides services for asylum seekers. Please give a warm welcome to in this panel. So we may not be able to cover everyone's questions today, but we'll try to get through as many as we can. So the first question I have is for Sharda ji. What symptoms should parents look for as indicators of mental health concerns, such as anxiety or depression, and how early can symptoms show up?
That's a really good question to start off. Symptoms that parents should look for, or everyone should just look for, are changes in mood, things that are out of the ordinary or persist. Lots of things can happen time to time, on occasion, and at certain ages can happen. For example, in children, crankiness can be due to sleep regression or not sleeping well. So the things you still want to look for are changes in day-to-day behavior. If someone has behaviors that are out of the norm, things that they normally enjoy, like hobbies, school activities, things that they normally enjoy, if they're not enjoying them as much as they normally do. If they don't want to go to school for some reason, or are having some anxiety or some separation anxiety, day-to-day activities too, keeping an eye on those. Some of the symptoms you can look for in their habits, with their sleep, their appetite. When it comes to sleep, if there's trouble falling asleep, staying asleep, or waking up in the morning not feeling well rested, that's something to look out for. Changes in appetite, not wanting to eat as much or eating too much, or sometimes even changes in the bowel movements like constipation or diarrhea, things like that. When it comes to anxiety for young people, they may think that they're breathing really fast, their heart could be beating fast, like what we refer to as palpitations. Their heart is racing. They can feel nauseous, and young children can be crying, tantrums, things like that can happen. And symptoms can occur in children quite young, even I've seen like as young as 3 years old. It's a little bit harder for them to express themselves, but what you want to look for, if they're hard to console, they cry easily, or if they're kind of regressing with their milestones of development. Those are some of the things to look for.
Thank you, thank you.
Can I take that as a cheat sheet for my practice? This was absolutely brilliant the way that you put it, right? Because she gave very,
absolutely.
She gave very concrete examples of exactly what parents should look for in their children in particular. Is my voice not loud enough, guys? Come on.
No, we need it for online.
Oh, the virtual. There we go. All right, well then, let me repeat the compliment. Okay, so Sharda ji did a great job of articulating to parents what are some of the objective markers that they can use to see that their child may be in distress, or there may be a budding depression or a budding anxiety syndrome. And she summarized it really nicely with these examples, but notice that what she did was she used biological features, but that were also, emotional in nature, so crankiness, changes in mood, isolation, not appreciating the type of hobbies or activities that the child or the person in general, it doesn't have to be a child, may be interested in. She used the physical features like nausea, changes in appetite, sleep disturbances, and then of course the social stuff, which we already talked about, more isolation and changes in things that they don't want. And then the biological stuff, what was a good example of some of the biological stuff you talked about there? What was it? I think you said sleep disturbance, appetite disturbances, and these types of things. So, and palpitations for anxieties, tachycardia, sweating, tremors. Sometimes you'll see some gross cognitive distortions that'll occur. Parents will be like, "What? I said this, and how did you conclude that from what I said? That doesn't make any sense. And same thing, like friendships, people will start having more arguments with the kids as well, because they'll be distorting they'll be distorting basically what is being received by them. So I'll stop talking at that point. Thank you.
Thank you for elaborating on that. A related question, I mean, you mentioned many of the things we can notice, but this question goes to Shriji. Are there some important areas that are normally not considered as contributing to mental health?
So in general, oh, thank you, sorry. Hope that this is clear enough, yeah. So in general, I kind of want to give some examples of certain things that we do on a day-to-day basis, because it's kind of easier to attribute to what is supposed to be norm and what is not so norm. So if you kind of start looking at activities of daily living, which is basically just taking care of self, we kind of breeze through without any problems on a day-to-day basis. But some of the folks that are kind of having issues, they kind of struggle with activities of daily living. And I kind of want to go beyond and say the instrumental activities of daily living, which would be paying the bills, being able to do the grocery shopping, being able to cook for the family, being able to do the laundry and cleaning and the chores, which kind of start to pile up when we kind of look at there is no specific diagnosis given to them, but these are the indicators that are supposed to be done without any hesitation on the part of the person or whoever we're evaluating. And that's kind of what we start to see that would be an issue. And also when we kind of look at a lifespan, we kind of see most of these struggles that are not supposed to be psychologically affected show up during puberty and growth spurts, and also in women, pregnancies and peripartum, postpartum symptoms. Similarly in men, the andropause, which is similar to the menopause in women. And these are the situations where we're supposed to, again, zoom through, not slow down or stop and have issues, but this is kind of where the symptoms can pop up. And the other example I wanted to put forth is even the kids that are really kind of like enthusiastic about getting into that specific Ivy League school that get in, and they kind of move to the town that they always wanted to live, and the job that they wanted to find, and get married, have a newborn, move into the house, and get promoted. These are all supposed to, again, happen without a breeze, but that's not what we see. So this is kind of where we kind of have to give the kids a little bit of the armamentarium to understand what are the struggles they could go through, because none of us come with a manual.
Mm-hmm.
So we just kind of have to wing it and figure it out the hard way.
Yes, absolutely true. And we are so used to having a manual for everything. Right? So going back to Shardaji, picking up on what you said, are there specific considerations when addressing mental health concerns in youth? Because many of the things mentioned, they could just be kids being kids, right?
Yes, a lot of these things do seem like kids are being kids, but when there are certain things that you want to bring up, as a primary care doctor, I tell people, tell parents and patients, share these concerns with your primary care doctor or your pediatrician. Typically, when you come in for annual exams, that's the time to bring up these concerns. We actually also have our staff screen patients, like pediatric and adult, everyone, for anxiety and depression. So that can prompt a lot of concerns come up. There are questionnaires that we will give patients to check for anxiety and for depression. If there's a concern for ADHD, sometimes we can ask people questions, and we can actually give parents surveys called the Vanderbilt forms to give to teachers and parents to get a good background information about those concerns. For younger children, we have to get a history from the parents or the caretakers that come to the appointments. And in this day and age with electronic medical record systems, when there's young people, have to be careful with how we put things in the chart and how we talk to people. So at first, we ask our patients and parents that we will talk to our children, patients by themselves, but we always tell parents that there's patient and physician confidentiality, but kids are allowed to speak to us in private. Things that we will share with parents are if they're a threat to themselves or a threat to someone else, then we do have to bring it up. I do encourage young people to share things with their parents, but a lot of times these conversations can be hard to have. So we'll help them kind of figure out how to talk about it, or even help them have those conversations with their parents. That's typically kind of what I like to do.
Thank you for that clarification. So going back to Shri, can you discuss the broader effects of unaddressed mental health conditions on the body? And what do some of these symptoms look like?
Right, so that's a very good question. Especially I see 18 and older adults, so they can obviously express their feelings and symptoms and concerns. Most of the times they do come in feeling extremely tired. Fatigue is one of their common. I don't feel good, I'm very exhausted. And the next one that kind of very commonly expressed is the sleep issue. Either they're having trouble falling asleep, staying asleep, or having very much so difficulty getting out of bed in the morning in spite of having 8 to 10 hours of sleep. So those are a couple of things. And as Sharada was mentioning, just racing of the heart, which is palpitations. And they also kind of have concerns about heaviness in the chest. So especially my middle-aged 40 to 60-year-olds, they come in complaining of chest pressure. I'm not gonna ignore. We just have to make sure it's non-cardiac before we kind of blame it on, but still, that can be a symptom that we notice. And shortness of breath doesn't have to be at rest, but with exertion and things of the kind. When they want to do certain things, they want to catch up on stuff, but they're not able to keep up with the kids and the rest of the family. Also, I do notice the lingering nausea as one of the symptoms when they're anxious and when they're unwell. And they also have the reflux symptoms. Diarrhea is one of the symptoms of IBS that we notice, that also can be associated with anxiety as one of the common symptoms. And just any tingling, numbness, especially of the upper lip and the fingers, that could be a sign of anxiety as well. So we kind of want to make sure that we are not concerned about their neurological function, even though we still need to rule that possibility out. And the somatic symptoms of joint pains, the muscle aches, and mostly the kind of blah, tired, I don't feel good. That's kind of the main thing they come in with. Once we kind of look at the full evaluation of their lab work and the necessary things, if we can't find anything, that's where instead of brushing it off, the patient that kind of is really looking for help, we need to delve in deep into to see what could be causing their symptoms.
If I may just piggyback on that, I think you explained it really well, and the question was what might these symptoms look like that are markers or clues that somebody has a mental health condition, depression, anxiety that's being unaddressed, and how may it manifest in the body? And Dr. Goganini and I have had these conversations before about what is the underlying pathophysiology of this phenomenon. And I think, Shri, you and I have said that we're moving away from this mind-body connection, which at first sounds bizarre to say that, hey, they're not connected, the mind and the body. Well, our argument was, yeah, they're not connected because they're not separate to begin with. It's a singularity, not a duality. And one of the ways and one of the things that we've learned, and this is somewhat old research now, but one of the things that we learned was with the cardiovascular system and depression and anxiety. So if someone's having depression and anxiety symptoms, chances are that there's a deficit of serotonin. Great, so what? In the brain only, right? No. One of the things that we've learned is that platelets have serotonin 1A receptors on them. And when you have a deficiency of serotonin, for example, sure, it'll manifest in the brain as depression and anxiety, But in the cardiovascular system, it'll manifest as clots, blood clots. This is not the only mechanism of blood clots, and perhaps a minor contributor to blood clots, for example. But when there's a shortage of serotonin, that 5-HT1A receptor living on those platelets is not activated, and that promotes clumping of cells. And we saw this in epidemiological research where patients who had had heart disease, heart attacks particularly, myocardial infarctions, had a proclivity to being depressed and anxious. And the first response was, no, duh. Of course, if you had a heart attack, you're going to be depressed and anxious, right? But we also realized that the inverse was also true. Patients who were more depressed and anxious had a higher rate of myocardial events in general. And certainly in the GI tract, what is it, 80% of all serotonin receptors are in the gastrointestinal tract? That's why when people get anxious, they have a lot of inflammatory bowel syndrome type of things, nausea, diarrhea, and so forth, right? When we were little babies in our mother's wombs, the brain and the GI tract were derived from the same ectodermal tissue. So that's why. So again, it's a singularity, and now we understand the reasons why depression and anxiety can also present with so many physical symptoms and how that should not be ignored, and that we should realize that there's untreated depression and anxiety there as well, and vice versa.
Okay, thank you. Yes, and ulcers is another one, if I'm not wrong, right? So, yes, so speaking of the terms, many of the terms that we hear, it would be nice to get some clarification, especially like neurology was thrown in, and another ones that come up are neurodivergence or neurodiversity. So this question goes to Thanjina. Neurodivergence or neurodiversity is a term that is being talked about. Can you explain what it means and its connection to mental health? For kids and adults exhibiting this, what are good first steps for parents or adults taking care of these children to go about receiving support?
Okay, so it's 3 questions. I'm going to trying to make sure I answer all of them. So the first thing I'm going to do is break apart what neurodivergent means. Let's just break apart the word. Neuro is brain, and divergent means different. And so when we say that, it's such a catch-all term. It can apply to so many people, but basically it just means their brains are wired differently. It's what we refer as an atypical child. And so the best way, I mean, when I say that, okay, you broke down the word, what else does that mean? These are the kids and the people that might have ADHD, that are on the autism spectrum, that have dyslexia, that have Tourette's. And so anything in the brain that's just slightly different. What I really want to emphasize is a lot of times people don't want the label. They don't want the label for their kids, and that is doing a big disservice, because it's not a negative thing to get that label. By getting that label, you're getting them the support, and you're unlocking your child or your full potential. And this ties into the next question, and I'm going to give an example that will probably illustrate it best. So let's say you have a child with ADHD, undiagnosed. They are sitting in a room getting ready to take a test. They're unable to focus. They are distracted by the student next to them. They're distracted by the thing out the window. They're distracted by a thought that they had about, what am I going to have for lunch today? And then the next thing you know, it's the time is up. And then the anxiety kicks in. When we do testing, a lot of times ADHD symptoms and anxiety also mimic each other, and so we're also trying to differentiate and also decide, okay, is it both? Is it one? Is it all these things at once? And so when that anxiety kinks in, they're like, oh my gosh, I'm gonna fail, I did so bad. And then you have a child whose self-esteem goes down, and they don't wanna come to school. And next thing you know, they have a stomachache the next day because they don't wanna go to school. And so when we don't address these things, we aren't able to get these kids help. When we get these kids help, they have accommodations. You get a student that's like a D or C who turns into an A student. One thing I will say in my clinical practice, without identifying information, all my CEOs have ADHD. I will tell you that. Being on the spectrum is not a bad thing. These are creative people. We just have to figure out what their strengths are and help them to use that. It's a known fact, Bill Gates is on the spectrum. And so again, these are highly intelligent people that just need support. The other thing is, a lot of times, It can go undiagnosed because kids are gifted or they have high IQs, and so they go through the school system doing great, or they don't get the support because academically they're doing really well, and they're just not stimulated. And if we find out that we need to provide them with more, just imagine how much more they can do. I usually see these people as adults because school is structured. Parents were always on their back making sure they did everything. College is semi-structured. Sometimes they struggle. I've worked mostly with the military population, and if you think about that, you go from school to a very structured military setting, and then we release all these guys who have head injuries and all these other things, and they don't know how to function because you pulled away all the structure, and there's just so much going on. And so again, we just need to figure out, if your child is neurodivergent, it's not a bad thing. I know it's scary to have that label and it sticks with you through the school system, but again, you are providing so much more help by getting, your child assessed. Let me make sure I'm getting through all the questions. Kids and adults, so receiving support. If you sense something, you have to be your child's biggest advocate in the school system. That's one place where you can start. Reach out to the teacher. They have a resource support person. Get their information. What they will do is I think I will talk about this later, but like a psychoeducational test. You can also reach out to your pediatrician and say, hey, I think there's something going on. You are with your kids the most. You understand them. You see their frustrations. You see what they're good at. At the end of the day, we have to be our children's biggest advocate if we sense that something is off. I hope I answered the 3 questions.
Thank you. Yeah, we try to pack in as much as we can. Yes, so you touched on ADHD and schools and colleges. So the next question goes to Sudhita, who's an ADHD coach, which is, what is the role of ADHD coaching in ADHD management, and how is coaching different from therapy?
Really good question, and you set it up perfectly, so thank you. First of all, ADHD is there lifelong. So even if you were identified as a child, it will stay with you. And even if you were not identified as a child, it's now especially, there's more awareness, and because of the pandemic, some of those structures that Tunjina was talking about falling off, there's a lot more adult ADHD diagnosis happening. So coaching is one aspect or one way to help you manage your ADHD. There's medication that, your pediatrician, internist, and then Dr. Singh's psychiatrist, they can all help with that aspect of it. There's aspects of therapy and testing that, people like Tunjina, or if somebody, Sonia's is mostly adult population, but there are clinical social workers who work with younger population. Where coaching comes in is we're present and future focused. So let me give you an example. I have a client who's really, like she said, very high IQ, but school was hit or miss. There were some subjects great, some kind of really blah, and the parents were wondering what this variance was of why, and it didn't matter rewards, motivation, what is the issue? ADHD is an interest-based nervous system. We come under that neurodivergent category where our brains are just wired differently. So if the subject was fascinating, it was very easy to engage and work with it. If the subject was not fascinating, then procrastination, everything kicked in, there was no desire to do anything, and then there was this last-minute rush to push things out or not do stuff, forget homework at home because it was sloppily done and everything. So when we started working, we looked at what were areas of interest and what were strengths. What was she good at? What was, there were things that she did very easily, but there were things that she struggled with. So what coaching does is bring in some of those skills that may come naturally to people who are neurotypical, because the world is designed for the people who are neurotypical versus those who are neurodivergent. So then we have to adapt and learn and figure out how we fit in the system and how we navigate every day. And intelligence is one piece that will help you, like Tanjina said, they may do really well. They may even do really well in college. I have doctors I coach who even finished their residency and then couldn't pass the specialized boards they needed to do. They were in programs for like neuroradiology and things like that, but then they couldn't pass the exam that made them board certified, or couldn't get through the last few steps of medical school, or struggled with, I have attorneys who could not either pass the bar or were working with their day-to-day workflow. Fortune 500 executives, work was going great, home not so well. This student that I was talking about that I started working with just now got accepted to a top 5 program in their area of focus. A year ago, this would not have been possible for them because everything was all over the map for them. But now the grades are consistent, they're making A's and B's, and more than that, they learned the skill of how to manage their workload, even if it's not of interest, and how to work through and build mile markers, use skills, use planners, whatever else there is to do that. So it's skills versus, usually those are the kids that hear you have so much potential, but you're not performing well, or the adults, the same thing. When we interviewed you, you wowed us, and now there's not one deliverable that's coming in on time, so.
Yeah. And to the second half, Ami, that's your specialty. What support is available in the schools and colleges for the students beyond what Tanjina already mentioned?
Yeah, I think Tanjina and Sudhita did a great job of talking about a lot of the struggles that kids face. And when you think about school settings, K through 12, kids are spending a lot of their time there, a lot of their day there. And so the teachers, other supports in the school are seeing the kids and seeing the struggles that they're having. And so when you think about the supports, sometimes that might manifest in a classroom with struggling to pay attention or lack of sleep, lack of attention, maybe their grades are slipping, and you're starting to kind of put together like what is going on for this child. And so teachers are kind of that first line of identifying some of that, and so that's sometimes brought up to the school psychologist if it seems like something that's often occurring. And that's when the school psychologist comes in and maybe observes a student in the classroom or various different settings in the school. Might test them. So there's cognitive tests that can be done, academic testing that can be done. There's rating scales, which are essentially surveys and questionnaires that can be given to the student, to the teacher, to the parent, to really get a holistic view of like, how does the child function, or where there could be struggles and challenges for them. And that way, we as the school psychologist, but also we partner with a lot of others, in the school, which is school counselors, social workers, outside of the school, if there have been pediatricians involved, psychiatrists, to kind of get a big picture of, okay, how do we go about best supporting the student? And so there's a couple of ways that you can go about supporting the student if you recognize that they have a learning disability. And that's through IEPs and 504s. An IEP is essentially an individualized education program. And so if a student is identified as having a disability, that's essentially a plan for them of all their supports that they can have in the school setting. So might look like supports in the classroom, check-ins at the beginning of the day, end of the day, and how to really support them so that they can succeed educationally, and also outside of the school setting in their day-to-day. And that's something that's constantly reviewed and changed because, of course, as humans, we're changing every day, and maybe we learn to cope with something a little bit better. And so we're always looking at those supports and changing them and adding things as needed. And then 504s are really for any student. It doesn't necessarily have to be a student with a disability, but similarly, it's just what are the supports that are needed for the student in the classroom to allow them to do the best that they can when they're walking in the building. And I think a big piece too as a community and kind of figuring out like how do I get involved in the school and get more information on this is I think school psychologists and school counselors are kind of like your first line of defense, and work really closely together along with school, social workers to talk more about that and identify that. And I think oftentimes we're hesitant, I think, like some of you had mentioned, of labeling and diagnosing, which can get tricky. And I think just given in our culture, in South Asian culture, the stigma related to that, or the pressure to succeed and that we do well educationally, and sometimes we're missing that there's students that are really struggling, and a lot of it is just they just need the right support to make sure that they do succeed.
Thank you, thank you. Yeah, then those are some good pointers for all parents. Next question is for Sonia ji. What are some common issues you have seen that individuals bring to your therapy sessions?
Yeah, so I provide talk therapy, and what talk therapy is sort of a confidential space for people to come and talk about, be able to process things that might be contributing to, anxiety, low mood, other stressors. A lot of times people might come to me after seeing their physician, because like Therese said, sometimes it's, okay, we need to go deeper to see what is the stress, what's contributing to that. And so a lot of times people might come because their doctor is like maybe seeing a therapist, because a lot of times with talk therapy, we're actually seeing our clients a lot more frequently than maybe they are seeing their primary care physician. And so a lot of times people are kind of feeling stuck. They're like, I just keep, feeling like I'm not getting better, or I'm just dealing with the same problem. I'm talking about the same problems every day with friends and family, and everyone might be tired of me talking about it, and so I wanted to go to a space where I won't be judged, that I can get another perspective, like an objective, person that can kind of, offer different insights. A lot of times it's also a place to be able to just increase their own self-awareness as well. And some of the topics that people come to me might be, they might have been struggling with anxiety their whole life, and they're at that point of this is starting to impact my relationships, it's starting to impact my performance at work. And so as a talk therapist, I'm really trying to help them enhance their coping strategies, and educating them a little bit more about the symptoms and how our brain works when it comes to understanding what thought patterns might be contributing to our emotions, and how our emotions then contribute to our behaviors. So providing a lot of psychoeducation about how our brain works when it comes to processing feelings. And so, somebody might be coming also with a specific stressor. Perhaps they're dealing with a relationship conflict and they're looking for ways to communicate more effectively, or they're looking at how can they be less reactive. Maybe they deal with struggles with anger or frustration, and they want to be able to have more harmonious relationships with their parent or their partner. And so we'll work on sort of, developing, strategies around doing that. I would say, like I said, I work with a lot of young South Asian adults, so college-age students or recent college graduates. A lot of times people are coming because they're sort of, feeling like they're not meeting expectations that maybe the family had of them, or they're feeling conflicts between values, being bicultural, growing up in a South Asian household with specific values, and then, in school with the Western values, and sort of being able to navigate that. And so, we kind of, talk through that. I really try to make sure that I'm also culturally attuned, and luckily in the last several years, there's a lot of great materials that are being produced by other South Asian therapists to kind of help normalize and validate the experiences that my clients are coming with, so they feel less alone. Because a lot of times people are coming to therapy because they're like, I'm feeling like I'm the only one going through this. So therapy can be very helpful in being able to normalize and validate their experiences as well. And so it's, I think it's just more of it's also a place for reflection, because I always tell clients that reflection is rehearsal for future behavior and thinking. So it's a good place to be able to sort of, practice and have, usually we're meeting I'm meeting with clients weekly or every couple of weeks, just sort of depending on the level of support they need until they sort of reach the goal that they may have come into therapy with. And so it's a touch point to be able to like apply these skills in the real world, and then see and then process it in our sessions to see where did they feel stuck, where are they still experiencing the stress, what strategies are working, what strategies are not working. And a lot of times as therapists, we use like evidence-based approaches as well. And the other thing to know about talk therapy is, like, I'm a licensed clinical social worker, and so as a licensed clinical social worker, I'm able to assess, diagnose, and treat symptoms related to mental health. I just cannot prescribe medication, so that's a big difference between some of the other professionals here. And a lot of my services are covered by insurance as well, so many of the clients that I work with use their insurance to get therapy.
Yeah, thank you, Sonaji. You mentioned resources. So there will be resources shared with people who have registered. If there is anybody in the audience here who has not registered, they can just give their email address to Lavanya, who's sitting there. Also, if any of the people in the audience who are physically present here feel more comfortable writing their questions, they can give their questions to Lavanya on a notepad also. She has some paper and pen available there. Right, so going back to the questions that we already have, Soniaji, you mentioned therapy, what a session might look like. Similar thing goes for Tanjina ji. What might a neurophysical evaluation look like? What could that process look like?
So I'm going to describe the different types of evaluations, not just a neuropsych evaluation. Before I do that, I just wanted to piggyback off of some things that Sonia was saying. A lot of times I hear, well, I can just talk to my neighbor, or I can just talk to my friend. Sonia and I are professionally trained on specific issues. These are evidence-based techniques that we are trained in, and what that means is these are techniques that are backed by research, extensive research to support it. And what it's not just a space to talk. I'm gonna break it down in a different way. So we wanna think about therapy as exercise for the brain. We are creating new muscle memory that's going to help you deal with depression. I'm trying to give an example in terms of if your thinking is getting in the way of you succeeding, we're changing those neural connections to be more effective. And a trained provider is able to recognize your patterns and meet you where you're at to help you to understand it, help you to see how it's impacting different areas of your life. And that's what the therapy space really is. It's not just, okay, I'm just going to have cha and chit-chat. It's a little bit more than that. And so that's what I just wanted to add in terms of why you would go to someone like Sonia or myself, is that we are using empirically supported treatments to help you. It's not just talking.
Sanjina, can I add actually something to that? So one of the questions that comes up is, hey, my child is not doing well in school, or I am not performing it well at school, at work. How about an educational coach, like more tutoring, more subject matter specialists, or a life coach or a leadership coach? And absolutely, all of those have a place, right? But again, like Sanjina, Sonia, or all of us here, we're trained and specialized in the areas that we are here representing or talking about. So somebody like me, a certified ADHD coach, specializes in how to work with the ADHD brain. That's different. It's not good or bad, it's just different. And so that the skills that come in or the conversations we have around that are different than maybe what an academic coach would have, because they may not understand the reason behind this procrastination, right? Or they may not understand why, when the conversation about or the homework was even done, it just didn't get put in the backpack and given to the teacher, or forgotten even if it was in the backpack. Or the deliverable was planned, but then somebody forgot to hit submit, and it never made it to whoever it was supposed to go. So this value in training and education that everybody has invested in is really important. So when seeking help, asking those questions about how people are trained or what their specialization is, and why would I go to a coach versus an ADHD coach if ADHD is my issue. So.
Okay, I'll get back to the original question, which was the process for a neuropsych evaluation. First, I want to break down, you don't necessarily need a neuropsych evaluation. There's many different types of evaluations. From the school system, you're most likely going to get a psychoeducational, and that is taking in the academic piece and the cognitive skills together. You can get those done outside of the school system as well. Then there are psychological evaluation. Those focus more on the emotional, cognitive, behavioral functioning, personality, intelligence, mood, and general mental health. And then we have neuropsych evaluations. And those are more specialized in the sense that we are looking for functional impairments or functional strengths and challenges. And so an example I can give you is you can go get a brain scan done after you have a stroke. Great, you see where it is. But what a neuropsych evaluation is gonna do is it's gonna assess what are your functional limitations. Is your processing speed, like do you hear information and you take longer to think about it? Is your memory affected? Is your attention affected? And so we are assessing your abilities from that sense of what is the functional impairment or challenge that is happening in our neuropsych evaluation. I say you don't necessarily need to get a neuropsych evaluation. You can do a psychoeducational or psych assessment because insurances don't want to pay for a neuropsych evaluation. They cost a lot more because it's much more extensive. So you can talk to a professional to decide, okay, what is the best type of test for my child or for myself? And go from there. If you're someone who plays sports and you've had multiple concussions and you're noticing something and you're struggling in school or you were struggling before, then a neuropsych assessment makes sense. If you're not sure if someone is, if it's anxiety or ADHD or someone on the spectrum, a neuropsych assessment might make sense, but you can try some of the other assessments as well. A lot of times, they're also, kind of to go over the types of different assessments there are, we also do health assessments. And so let's say someone getting a organ transplant, they would be required to get a psych evaluation to see how successful they're going to be with that transplant. And so when you hear psych evaluation, people are like, oh my gosh, they're gonna see if I'm crazy. That's not the case. When you think of that type, I think the first thing people think of is in a court system and sanity evaluations. Those are forensic evaluations, forensic psych evaluations. Your kids are not going to be taking those. And so I just want to clarify, it's really confusing. And so really the first place to start, if you're in the school system, is a psychoeducational evaluation. If your child has other concerns, you talk to your pediatrician about it, and then you can get a neuropsych referral. And so to go back to the question, how would you start that process? Ask your pediatrician. Your pediatrician will know, okay, this is typical, or your family doctor, we expect a child this age to be this way. Well, okay, I can see that. The other piece, again, I have to emphasize is you are your child's biggest advocate. You as a teenager are also your own biggest advocate if no one else is listening to you. You as a young adult in college are your own biggest advocate. If you think if you're struggling, you have to advocate for yourself if you want the support. I hope that answers that question.
Yes. So going to Ami, a lot has been mentioned about benefits, but is there anything that has not been mentioned in terms of benefits or challenges of someone getting a diagnosis compared to not getting one?
Yeah, I think, in addition to some of the benefits that were mentioned, of course, is that like specialized support, like getting a sense of like what's going on and then being able to pinpoint, what support do I need to target, what I'm struggling with or what the student is struggling with. I also think, in addition to that is the adults that are supporting the student, right? I think like Gina, you were saying like, as parents, you or as individuals, like you're your biggest advocate. So as parents and for a child or caregivers, guardians, whoever's really a big support of the student or child, gives them some insight on like how can they best support their child at home. or just throughout the lifespan, and really giving them the tools that they need to be able to succeed. I think the challenges that come with it too are, of course, there is a stigma, right, of being diagnosed or being labeled, and how to navigate that. And I think a lot of it is this advocacy and open conversation, and hopefully this is helping to dismantle a little bit of that here. But recognizing that we all struggle in our own ways, and everyone is different in what they need and the supports that they need, and that starts at a young age. So how can we ensure that they are getting that support at a young age so that they can succeed as they go through their life? I think another piece in terms of diagnosis too is misdiagnosis at times, or underdiagnosis. And so misdiagnosis being, if something is, manifesting in a certain way that looks similar to depression, anxiety, or let's say learning disability, and that's not necessarily what's going on. And so the supports that they're being provided don't match up with what they actually need. And underdiagnosis, I think, is something that, can be maybe common in our South Asian culture because of this idea that, we're successful and that we do well, or maybe the symptoms that, or things that we're struggling with manifest in a very different way. So, individuals in a school setting, for example, right? If you're doing really well in school and you have really good grades, teachers may not think anything's wrong. Maybe your behaviors aren't manifesting similar to other students that might be acting out, or maybe it's very visible they're not doing well in school. So the way it looks could be different for everyone. So ensuring too that we're not losing track of some of those students that might be flying under the radar that need that additional support too. So I feel like there's a couple of different ways to look at it.
Actually, that ties in with one of the questions we've received online, where a person says that from their personal experience, everything is a hit or miss, including diagnosis. So maybe this is something, Dr. Singh, you can answer in your next question, which is, what is your role in mental health compared to what other panelists have spoken about? When looking for a psychiatrist, what should people be looking for? So again, two questions packed in one.
Absolutely. And just sitting here and absorbing the insightful comments of the panelists, I was tempted to make comments, and I was like, no, I'll just wait my turn. I'll wait my turn, because they said such wonderful things. It's interesting what you were commenting about diagnosis, right? There's been a big movement in the NIH called Research Domain Criteria, where as physicians and surgeons, we're now told to, yes, diagnoses are very important. They absolutely are, and they help inform guidelines and pharmacologic or surgical interventions that are made, and they're evidence-based and research studied, but not all of them are, and not quite precisely. And so we're being told now to identify symptoms and then to target those symptoms with our content knowledge of pharmacologic interventions or surgical interventions to try to help alleviate those symptoms. And in fact, that's what the NIH calls them, the symptoms. They call them the target symptoms, because that's what we're going to be targeting. So diagnosis, very important, but in terms of medical decision-making, perhaps not as much as the symptoms are, for example. And also, interestingly, in medical practice, one of the things that we do in I'm a director for brain injury programming for Advantage Healthcare Systems and for chronic pain programming. So we have a big team of anesthesiologists, physiatrists, which are pain management specialists, non-surgical pain management specialists, chiropractors, occupational therapists, speech-language pathologists, psychotherapists, and then I'm a psychiatrist. But one of the things that we order quite a bit is things like x-rays, right? When somebody has an injured spine and they're now out of work and they're not making any money anymore and they've lost their job and they're feeling horrible about themselves and they've sunk into a massive depression, anxiety. So they have both mental health concerns and physical health concerns. And we order x-rays, and our colleagues, the radiologists, will come in and they'll say, wow, this is a compound fracture, and then they'll make recommendations what to do next, like this is surgical, this is not surgical, right guys, when you get x-rays ordered, right? And same thing, like Dr. Ahmed over there, what I'm thinking over here, scratching my head and going, wow, so this person has had not only orthopedic fractures, but also concussions and depression, anxiety in combination, but the neuropsychiatric symptomatology, which no one can make sense of because they're presenting with ADHD-like symptoms, because there's a cognitive domain when your neuronal circuits are cut from brain damage and they're no longer talking to each other properly. But it's not because you're making too little serotonin, norepinephrine, or dopamine. it's not physiologic in origin, it's microanatomical in origin. Your brain circuits got cut from the shearing forces of banging your head back and forth. And they're presenting with symptoms of anxiety, right? Makes sense, because the functional regions of the brain on a brain scan are going to show up perfectly spotless. They're going to be intact. But the patient's now having anxiety symptoms, depressive symptoms, explosions, mood oscillations, and also then physical symptoms. Sleeping problems, fatigue, ear ringing tinnitus, balance problems, hence the occupational therapists and physical therapists on our team. One of the things that we order quite a bit as a, if you will, a x-ray that we use quite a bit is neuropsychological testing. So we will actually request that, and that gives us an insight to what the heck is going on with the patient. Is this a neurocognitive disorder secondary to traumatic brain injury, or is there some other process going on as well? So, and like the radiologist and neuropsychologist will offer some comments on what interventions and treatments we can use. So I think we've got a pretty cool team here, different than my team in Dallas, Texas, where Advantage is located, but this is outpatient bread and butter psychiatry and psychology, right? So where the heck do I fit in this? I don't know. You know, it's a good question. So I didn't have any idea. So what I did was I called up one of my good friends, Dr. James Long. He's an internal medicine doctor. You know James, right? Yeah. And I said to him, I said, look, where do you view me on the mental health team? He's like, and he draws this parallel of psychiatry and orthopedics. He's like, you're a psychiatrist. I look at you like I do an orthopedist. I said, not like an internist? He said, no, not like an internist. As an orthopedist, psychiatrist. I said, what do you mean? He goes, look, if I have somebody who comes in with some pain or something like that, yeah, great, I'll request an x-ray or whatever the case may be, but I'll make a referral for orthopedics. Now, where the heck does it go? Does it go to physical therapy, occupational therapy? What's going on? And if the fracture is mild, maybe they don't need the orthopedist. If it's a hairline and it's going to heal by itself, fine. But if the x-ray shows something much more significant, then maybe they do need the orthopedist and it's a surgical intervention that's required. Same thing for me. When it gets to the point of where it becomes medical, in particular pharmacologic, that's where I come in. And so if the symptomatology has graduated to the point where it's significantly distressing, significantly causing social or occupational dysfunction, then pharmacology is indicated at that time. That summarize it okay? Kind of, sort of, not really, maybe? Perfect. There you go. And so what the heck should someone look for when they're trying to find a psychiatrist? Number one, somebody who has openings. Pretty darn packed. But number two is you want to, the science in neuropsychiatry, these brilliant neuroscientists out there, the medicines that we have created over the last decade are phenomenal. But it's also phenomenally challenging to keep up with all of them, because they're so different in that they're now looking at neuronal circuits, and we're targeting neuronal circuits in the brain, which we've never been able to do before. Before, we were thinking of neuropsychiatric conditions as a function of too much of a neurotransmitter or too little of a neurotransmitter. Forget that. Now it's more specific. Which neuroreceptor and which circuit and which part of the brain? And we're creating medications based on that content knowledge that specifically target those receptors of interest in proportionality. So one of the things you want to look for is somebody who very much is in tune with the latest science research. How do you do that? I don't know. Maybe you look at somebody who gives lectures, somebody who does continuing medical education credits, is teaching, faculty appointments at different universities, and these type of things might be good insights. But the best people to ask are your primary care doctors, because they're the ones who get the feedback from the patients, and your psychotherapists, because they're also the ones who get the feedback from the patients, and that's very important. But I'll leave it at that, and if you all have any other insights as to how someone would go to find a good psychiatrist, please.
Yeah, you mentioned something really good about feedback. As a primary care doctor, when I see people for well child or annuals and they come back to see me again, I'll ask them, how are your visits with your therapist, or how are your visits with your psychiatrist? A lot of people will be afraid to say if something's not working, or they're afraid to say they're having side effects of a medication. And it's really important to me as your primary care doctor to say, hey, you need to speak up and say if you're not feeling well or something isn't working. You need to be comfortable talking to your primary care doctor, your team members here, if something isn't working, to speak up without feeling hesitant to let them know if you need to go on a different path. So finding someone that you can trust to speak up to is really important.
Yeah. Go ahead.
I was just going to add to also being open to coordinating care, right? Because a lot of times your physician may not be in the same office as your psychiatrist or your therapist. So also seeing whether, like the psychiatrist, are they open to coordinating care with the therapist? Because then, just signing a release to allow certain information to be exchanged between the providers, so that, we can talk to each other professionally about what we're observing, why did you prescribe this particular medication for this particular client? So just being able to sort of integrate the care is key as well.
Yeah, and it's interesting because one of the things I forgot to mention is that whenever we're dealing with patients, especially in psychiatry, it's so confusing, right, as to what medication and why. And I love the therapist. I love the collaboration with the therapist, and a lot of you guys love actually wanting. You're quasi psychopharmacologists. Like the questions that are asked, like, oh, why this medication? Why was that? Oh, what circuit does that hit? Oh, okay, that makes total sense. Is that why this patient had side effects on that medication but not on this one? Right, it makes sense. That's why they were switched, et cetera. So it's really fun to collaborate. Because the inverse is also true, right? Which is, look, I may treat a patient, right? I spend shorter amounts of time with each patient than a psychotherapist would. And the patient comes in and says, yeah, I'm doing much better. I'm so much better than the first time we met, and blah, 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 and this is good, this is good, this is great. And then I get a phone call from the therapist saying, well, maybe not precisely, right? There are these functional aspects in the patient's life that are still compromised. Now, the patient didn't think to say that, right? Like my father had some knee pain. He went to the orthopedic, goes, yeah, much better, et cetera. Yeah, this is great, And it was truly a substantial improvement. But that's when I said, well, yes, but you still have X, Y, and Z deficits. And the orthopedist was like, thank you, and made some further interventions. But in the mind of my dad, he's like, thank you, this was absolutely fantastic, and he was relatively satisfied. So I think that collaboration piece is actually a very good point to make.
And if I may add to that, pretty much every one of us, we're bound by HIPAA laws or ethics and principles where everything that's discussed with us is kept private and confidential. Even if they're younger students or young children that we're working with and all of that. There's systems we set up where parents are aware of it, or if somebody wants their partner involved in it, that they're aware of it. And the only time we break that confidentiality, and somebody mentioned that, if we believe that they are a risk to themselves or somebody else. So in order for us to collaborate and for us to talk, we do ask for releases from people. Like, for me to reach out to your internal medicine specialist, or for them to reach out to me, or your therapist to reach out, or psychiatrist. So having those systems and having those options for us to collaborate only makes the care better, because what a therapist or a licensed clinical social worker or a psychiatrist or an internal medicine is seeing is different than what I may be seeing in an ADHD coaching session. So that collaborative approach, so assembling a team around you of people that you believe in, that you trust, and that you give permission to, so we can all talk to each other and support you better.
Great. Sonia ji, so how might counseling therapy help individuals cope with situations they may be unable to control, particularly in the context of cultural factors and or family partner relationships?
Yeah, no, that's a really good question. Because there's like a meme out there of like how a lot of times people are coming to therapy for the people who might need therapy, whether it's like, a coworker or family member or partner. And so a lot of the work is, really identifying what is triggering you in the situation, because we're going to work on focusing on what you can control, because you can't obviously change the other person's behavior or thinking. So what is it, what's in your control, and oftentimes it's your reaction. So understanding what is it that's actually activating you, and understanding maybe how you might be contributing to the particular dynamic. Also being able to understand where the other person might be reacting from as well, especially in the cultural context, right? Like understanding what things might be, they may be coming from a different value or a different upbringing, or perhaps, this is, all the, they may not have the coping skills and the resources that you have now, right? So being able to develop some empathy and understanding of like where the other person might be as well. And then really focusing, and a lot of the work is also around accepting what is. This is what you're being presented with. This is, and so how, sometimes our suffering can come from resisting the reality of the situation. And so once we can get to that place of acceptance, it's like, okay, how do we manage our expectations around this reality? And so being able to figure out like what would work for you in this context, and how can you manage those reactions? It's like Tanjina also said, right? It's like a lot of therapy is exercising of the brain, so it's also learning, like a lot of times when we're reactive, it's coming from the emotional part of our brain, and the whole, like for our brain to be healthy, our thinking and our emotional side need to be online together all the time, but when they're not online, that's when we can become very reactive. And so being able to develop, learn some skills and tools of how do I get those two back together, which might be like learning grounding techniques, like deep breathing is an easy one to employ, so that we can get, because a lot of times when we're in our emotional brain, everything is tightened, our blood vessels, and so we don't have enough oxygen going. So it's like, what can we do to sort of get oxygen back into the brain so we can get back online and then be more strategic about how to manage the situation.
Yeah, thank you. So you talked about managing things, but Nikuji, from your perspective, when do you find medication is warranted in mental health treatment?
I think that one might be a fluid type of answer. When is it warranted? And it's really hard to say precisely when, but the nutshell answer is that when the symptoms are severe enough that they're causing social and occupational distress. Now, every diagnosis has a mild, moderate, and severe. And sometimes mild symptomatology in mental health may not necessarily require medication. Sudhita ji and I have had this conversation actually, where we've talked about mild cases, and let's use ADHD as an example, right? Mild cases of ADHD may not require any sort of pharmacologic intervention. And this is just by way of example. Why is that? Because if you catch ADHD as a diagnosis early enough, and it's a mild case, and you implement coaching therapy, and you allow those neuronal connections to form more properly as you teach them psychosocial skills, cognitive awareness, behavioral modification techniques, and things like that, then as those neuronal synapses form properly, then the ADHD symptomatology may correct itself quite substantially, that pharmacologic intervention may not be needed. But equivalently, if it's a more moderate or severe case of even something like ADHD, then good luck, because otherwise the patient is just going to be walking on his or her own eggshells. Every single day is going to be a challenge. They may have the cognitive processes to try to help, but they're always just constantly going to be stuck in their own head trying to see whether they're making an ADHD error or not. And their pharmacologic intervention is very much mediated. You flip it to something like depression, anxiety. I won't use the extreme example of something like schizophrenia or bipolar, but if you flip it to something like depression and anxiety, remember these diagnoses can be very severe in terms of outcomes. Like suicidality is not uncommon with depression at all, right? And so when the symptomatology gets to the point where you're having enough severity of symptoms, that's when pharmacologic intervention is mandatory at that point. There are a lot of situations where, and you have to assess and say, okay, is this a circumstantial or situational phenomenon? And if the answer is yes, then if you were to remove that circumstance or situation, would everything be okay? Yeah, and that's not depression, that's an adjustment disorder if the number of symptoms are not that substantial or severe enough per se. But could you still use pharmacologic intervention in that situation? Yeah, because in order for the patient to be experiencing symptoms, there has to be some sort of neurochemical change in the brain. So that may be a short-term use of pharmacology, but certainly if you run into situations where there are repeat episodes of depression, repeat episodes of anxiety, then that's a big clue that there is gene expression, and that would be a situation where medication, pharmacologic intervention is mandated.
So suppose it is mandated, then how would you address any stigma associated with these medications?
You know, if you'd that's another good question. If you had asked me this about 15, 20 years ago, the answer would have been that mental health is becoming more and more visible. Epidemiologically, more and more people were having mental health issues and therefore seeking mental health treatment, therapy, of course, and a lot of people were graduating into pharmacologic treatment as well. And about 10 years ago, I guess, I would say that the stigma was starting to lift even more because we as society were starting to realize that untreated mental health conditions can cause significant disability. I still remember about 12 years ago, I was giving a lecture at Princeton up in New Jersey, and I put up a slide from the World Health Organization. And it said the leading cause of disability in the world was, number one was, cardiovascular diseases. And I was like, what the heck is that? That's not a diagnosis. That's a category. That's like saying nephrological ailments, right? Next year, the World Health Organization cleaned it up, and they did it by diagnosis. So I was like, is this atherosclerosis? Is this coronary artery disease? What's the diagnosis? By far, the leading cause of disability on Earth was depression. Major depressive disorder, it still is. In the US, a close second is low back pain, but if you, but depression is still number one, and if you take it in totality and around the planet, it's still major depressive disorder. So I think now people were also starting to realize that it also had consequences of not treating mental health conditions. And nowadays, I would say that any of the stigma around medication specifically that people had around some sort of nefarious side effects and things of that nature, as we clean up the pharmacology, as psychiatry becomes more and more neurology, I think that all of that is going to start to change even more rapidly when the more sophisticated pharmacologic medications start becoming more commonplace. And also non-pharmacologic interventions like transcranial magnetic stimulation and things like that start to catch more of a foothold in psychiatry, in neuropsychiatry. I think the stigma is going to start to abate.
Yeah. Sudhita, do you see the same thing happening for ADHD?
Absolutely. It's really been interesting to watch this journey of how ADHD is becoming more mainstream. And by mainstream, I see like more accepted. And understanding that just because we're a certain ethnic population, we're not immune to this diagnosis. The numbers are pretty much even across all communities, races, ethnicities. And then people looking at all aspects, all modalities, therapy, medication, coaching, all of that to see that there are supports available. There's no necessity for somebody to struggle, have low self-esteem, have low confidence, because if you are continuously not performing well and having challenges across the board, whether it's school, home, whatever, the common denominator we all look at is, hey, something must be wrong with me. And so that leads, especially with children in high school, college, even postgraduate studies, this feeling that, oh, they diminish themselves versus saying, hey, my brain just learns differently. I may not be the great person at the multiple choice questions, but I can do really, really well with concepts, and I can write essay questions better. Computation is not my thing, but boy, do I understand integrals and differentials in a way that's very deep, and I can go down and go dive very deep into a certain topic and understand it. So it's really great to see, and it's great that the response and that so many people are interested in these conversations. Of course, the panelists all taking time to be here, so.
Yeah, thank you. Yeah, we are running out of time, so I'll ask a few general questions, and any one of you who would like to address them, please do. So first one is, why is getting help in all aspects, from a doctor to therapy, the whole thing that we have been discussing, why is it so expensive? And why do many of the best practices not accept insurance? What options are really available to families who cannot afford it on their own?
I'll answer a part of that, the latter question of why is it so expensive and why don't they take insurance. In my experience, insurance limits us in providing the best care that we can give to a client because we have to jump through so many hurdles. You have to be approved, all these different things. With that said, we do not advertise this, but you can ask, do you offer a sliding scale? Are there pro bono services? If we advertised it, it would take up our entire caseload. But you can ask. You can ask for referrals to community-based services. Yes, there's a long wait list, and I will say the pandemic sort of blew up, and we all have month-long wait lists. But sometimes I will tell clients, hey, if you can't afford the out-of-pocket psychiatrist, go to them, because they're specialized, they know what they're doing, and they will give you will get to the right medication faster. Then you can go back to your primary care doctor who is covered by insurance and have them continue that medication. So talk to providers of, hey, I would really like this, can you provide me with recommendations or referrals, or is there a way that I can get support in that sense? The other thing you gotta think about is, going to school and having education, it's not cheap in America, I'm sure you all know that. And so we are paying back student loans. We are also covering the cost of living. And so thinking about your providers, we also have to live, and if we could offer free services, we would. We would. So it's not, we have to cover licensing fees, we have to cover insurance fees. And so it's not just, they just see a patient and make money. There's a lot that goes into it, just so you can kind of have an understanding of, they're just upcharging us because they can. Well, our rates for insurance and things go up as well. Again, just ask. If it's cost prohibitive, just ask, hey, is there something you can do? Do you provide a sliding scale? Do you know someone who can see me? And people who don't have openings in their schedule, they'll try to help you, is what I'll say.
Yeah, and just to add to that too, one thing from the psychotherapist perspective with insurance, and why a lot of people may not be accepting too, is that insurance companies don't reimburse us at the rate that we might be publicizing as well. So it is sliding scale oftentimes for the provider. One great resource is EAP services, employee assistance programs, so places that you work. Your employer might, and it's not often advertised too much, but you can always ask your human resources whether your company has EAP benefits, because oftentimes it's free sessions. It may be for a short period of time, for one issue area a year. You could get up to like 3 to 10 sessions, and then you'll be connected to a provider, and like Tanjina said, then you can sort of talk to the provider about continuation, right? Like, do they know of any other providers that might accept your insurance that they know, or other resources? Because a lot of times we're at the local level in the community, we may know things that, resources that might be available for like sliding scale or pro bono as well, but that may be a good introduction into.
Just want to add, there are also nonprofit organizations that will help to cover the initial cost of therapy. One that's big in this area is called Akuma, and they work with people of color, and they will pay, I think, up to 8 sessions. And so you can look for nonprofit organizations that can help you to just get started. And oftentimes when you start doing services with someone, that provider, once you've established a relationship, is, will want to continue working with you, and we'll find a way to make it work.
One other aspect of that is students. So for example, in order to become a certified coach, there were a certain number of hours that I had to work with clients, and these were mentored sessions. We had to make recordings, so they were you were heard, somebody who was qualified was listening to them. And so students need those hours to graduate, and I'm talking in terms of ADHD coaching, right? We need those hours to graduate. So you can work with somebody, and you can put your name into the hat at a coaching school or whatever, and say that you are looking for services, and would a student work with you? And most of the time, the fee is much lower. And like Tanjina said, a lot of coaches We'll do sliding scale, which is, reduced or whatever, work with you on that pro bono. And then sometimes group opportunities also. There is coaching cohorts or therapy where you do it with a group of people. And actually sometimes that's really powerful because you're listening that you're not alone in this. There are other people who are in the same boat. So, so there are options out there. And I think multiple people said you have to advocate for yourself. You have to look for these, and sometimes it's not easy. But that's when you can come to your family medicine practitioner, your internal medicine, and within the field, we'll know where to direct you and where to go.
Thank you. So we are running out of time, so I'll switch to a question that was asked, and it's very open-ended, so please do the best you can. We are in a faith-based setting right here. So the question is, are there studies around faith-based or Sunday schools having an impact on mental health? Yeah, please.
Yeah, absolutely there are. So, in any sort of mental health clinician's education, whether in med school in psychiatry, internal medicine, and family medicine, or whether in psychology, there's been a lot of research showing that spirituality can contribute very heavily to good outcomes in health as well. As to precisely mechanistically what that is, the presumption is a sense of hopefulness, which can help reduce inflammation in the body and these type of things. Dr. Gugini, you may know a little bit more about that than I do at this point, but spirituality studies, but they've been more epidemiological, so they're not cause and effect, but they're association. And so people who have faith to fall back on have had better health outcomes in general.
And I think also that community, that connection, that the sense of belonging, because our brain is wired to want to connect, and so being able to have spaces of community connection is invaluable as well to better outcomes of mental health.
Okay, wonderful. Thank you all. Any last comments from any of you? Anything you wish was asked of you?
So as a primary care physician, I would encourage everyone that's kind of like looking for help to talk to their pediatrician, the family medicine docs, and the internists, and they're all willing to help you guys not have to right away jump to finding a therapist and a psychiatrist if you are not able to. But at the same token, we are limited in our training, so we just kind of have to find the best help that you need. And that's kind of when the referrals will be done and sent to the proper personnel as well. And coming from the South Asian background, none of us, myself and the physicians here, are not jumping to prescribing medications. One of the things that I wanted to insist on, and I wanted everybody to understand, is the medication is only prescribed when you needed it almost a month ago, not today. So we just kind of sit on it for a while before we jump on the bandwagon to prescribe. And I see quite a few of my patients that kind of stop them on their own because they started feeling better. So they kind of feel like they don't need it anymore. And that's kind of a big no-no, because I do expect them to talk to the prescribing provider. Dr. Google came about to educate us about the disease processes, but it cannot help you personalized treatment. So I definitely encourage everyone, before they change their medications, they talk to the providers, whoever prescribed them, or whoever they're comfortable with, before going ahead and stopping, because we always, unfortunately, invariably see people coming back with worsening of their symptoms and at a worse shape than they started out from the get-go.
I just wanted to add one thing about stigma associated with medications. I noticed in my experience with my patients, a lot of people feel like coming to discuss or consider medicine is like a crutch, like it's a weakness, like you have failed somehow, or there's a concern it's going to change you as a person, change who you are. And part of the process in starting a medicine with your physician that you trust is, coming back again and again to see how you do on a low dose of a medicine before getting to a dose that's therapeutic, seeing how you how your symptoms improve, coming back and forth. You know, we talked about, you know, misdiagnosis. You know, this is going to be a process. No one's going to write you a medicine and say, see you in a year. We're going to have you come back. We're going to have you see the therapist. We're going to think about neuropsych testing. You know, just taking a medicine isn't going to be the thing that's going to solve everything. It's going to be a process that you just have to trust your whole team to kind of help you with.
Thank you all. Thank you so much. Please give a round of applause to our panelists. They have provided us with wonderful information, and more resources are going to be made available to all online. At this time, I would like to invite one of our Vedanta teachers who's in the audience to come and give a small token of appreciation to our panelists. Arvindji, please, if you don't mind. Just give all 7. आप सबको देते जाइए, सबको। Thank you, Tanjani ji. Thank you, Sujata. Thank you, Shri ji. Thank you, Sonia ji. Radha ji. Thank you. Please, we will have some snacks for anyone who's able to stay back, and some of our panelists may be able to stay for a few additional minutes. So please enjoy. We'll go there. Thank you.